everyone. My name is Adila. Presenting TME topic peptic ulcer disease supervised by Dr. Haziq Hussaini. So for the definition of peptic ulcer, it is a condition when there is split in the mucosa of the GI tract that extends through the muscularis mucosa, submucosa, or even deeper. And then erosion is when the epithelial disruption without breach of muscularis mucosa happen. So peptic ulcer is a lesion in the lining of the digestive tract caused by local inflammation, decreased mucosal resistance, and also hyperacidity. And most of the peptic ulcer occur either in the duodenum or in the stomach, and it is rarely in certain areas of the small intestine. Gastric ulcers are due to decreased resistance of the gastric mucosa and commonly seen in all patients, whereas duodenal ulcer is predominantly occurs due to hyperacidity. And the incidence of peptic ulcer disease is approximately about 72 per 100,000 patients. So first, I would like to share about the anatomy of the stomach. Stomach is the most dilated organ in the GIT, and it is intraperitoneal organ, and it is expandable and J-like shape. The stomach is positioned between esophagus and also small intestine, and located at epigastric, left hypochondria, and also the umbilicus area. And the stomach could be divided into 4 regions, which is the first one is the cardia, second part is the fundus of the stomach, the third one is the body of stomach, and the last one is the pylorus, which could be divided into pyloric entrance or also pyloric canal. And the blood supply of the stomach actually origin from the celiac trunk, which gives into 3 branches, which are the left gastric artery, common hepatic artery, and also splenic artery. The common hepatic artery further branches to form gastroduodenal artery and right gastric artery before they are supplying the liver, which is the common hepatic artery. And gastroduodenal artery then branches to pancreas, forms superior pancreaticoduodenal artery, and becomes right gastroepiploid artery. And splenic artery further branches to form short gastric arteries and left gastroepiploid artery before reaching the splenic hilum. And the nerve supply for the stomach is coming from the vagus nerve, and they are about 80% sensory, and the 20% is for motor function, which for increasing motility, opening pylorus, and also initiating the secretions. Nerve supply for stomach also coming from the sympathetics, which is the greatest splenic nerve, 5 and 2 T9 for decreasing motility, vasoconstriction, closing pylorus, and also for the sensation. So the anatomic physiology of the stomach, as the stomach acts as a reservoir for food and commences the process of digestion. Gastric acid that is produced by proton pump in the parietal cells, which in turn is controlled by histamine acting on the H2 receptors. The histamine is produced by the endocrine gastric ECL cells in response to a number of factors, particularly the gastrin and also the vagus. The proton pump inhibitors abolish gastric acid production, whereas the H2 receptor antagonists only markedly reduce it, which these two are going to be the medical treatment that will be given for peptic ulcer patient. And then the gastric mucous layer is essential to the integrity of the gastric mucosa. So what are the etiology or risk factors for peptic ulcer disease? The main cause for peptic ulcer disease is having Helicobacter pylori infection and also NSAIDs. Those patients who taking NSAIDs like ibuprofen and aspirin are more likely to have peptic ulcer disease. Also, other factors are like lifestyle, which is smoking, regular alcohol consumption, and those who are taking spicy food. Also, psychological stress will lead to peptic ulcer disease. Right now I'll be sharing the difference between duodenal ulcer and also gastric ulcer. So the most common one is duodenal ulcer compared to gastric ulcer. And duodenal ulcer, we can see it is mostly occur in the first part of the duodenum, and usually in duodenal ulcer, the chronic ulcer penetrates the mucosa and into the muscle thickened, which lead to fibrosis and it causes deformities such as pyloric stenosis. And when the ulcer heals, a scar can be observed in the mucosa. And sometimes in duodenal ulcer there may be more than one. So in this situation, when there is both posterior and also anterior duodenal ulcer, we refer this as kissing ulcers. So duodenal ulcer will give rise to complications like perforation, which anterior ulcers tend to perforate and also posterior ulcers tend to bleed. And sometimes by eroding into the gastroduodenal artery. For the malignancy, duodenal ulcer is not usually associated with malignancy. Compared to gastric ulcer, for the location, it is mostly occur near the lesser curvature, especially the infraangularis. And in gastric ulcer, usually the ulcer will fibrose, and when it occurs, it may result in the now releasing hourglass contraction of the stomach. The complication of gastric ulcer is large and chronic. It will erode posteriorly into the pancreas and other occasions into major vessels such as penic artery. And less commonly, they may erode into other organs such as transverse colon. And most of us are knowing that gastric ulcer are commonly associated with malignancy. For the duodenal ulcer and gastric ulcer, usually patient will present having pain at the epigastric site and often described as gnawing and radiating to the fat. But duodenal ulcer, usually the pain, they are having pain before meal and at the middle of the night and relieved by next or however, in gastric ulcer, the pain is usually the patient having pain while eating and relieved by vomiting. So usually gastric ulcer patient they have poor health as they are afraid to eat. Then in peptic ulcer patient also they might have vomiting. However, in duodenal ulcer it is uncommon to have vomiting and commonly occurs in gastric ulcer after each meal. And in duodenal ulcer, the periodicity is common. However, in gastric ulcer it is less common. In duodenal ulcer, the tenderness are more at the duodenal point. However, in gastric ulcer it is more at the mid-epigastrium. And in both cases, the treatment that could be done is by transfer vasotomy with take 13 severe breath tests and also stool and urine test. And next for the invasive one, there are rapid urease test, biopsy urease test, last year also histology, where they will took the ulcer urine. Yes. Okay, these are the example of the test X-ray showing an unidentified operated. Also, it could be also operation into other organs. Then this is the example of CT scan. In a 68-year-old man with perforated duodenal ulcer, which came with severe inflammation pain and twisted duodenal size. On this CT scan, you can see PR and extravasated contrast material in very hepatic space. So, as I said just now, CT scan has no part in the primary detection of gastric ulcers. However, it has a role in the detection of subpenic and other collections that may occur after operation. The investigation that could be done in investigation of peptic ulcer are is OGTS, where it serves as diagnostic and also therapeutic. Diagnostic is with the OGTS, you can confirm the case of peptic ulcer disease and find the location of the ulcer. Second one, it serves also as we can do biopsy using the scope to rule out malignancy, especially if there's positive signs in terms of malignancy or appearance of ulcer. So you can take this test, holes around ulcer correctly. And then using scope, we also can take biopsy and urease testing, RUT or CMO test. The biopsy tissue test include lymph and urea and indicators such as picrorat, and the urease produced by his primary hydrolyzed urea gravina, which raised the pH of the medium. And if there's any changes of the color of the specimen from yellow to red, it means that the patient are having infection. Also, expurgogastroduodenoscopy serves as therapeutic, where during the scope we can do ligation of the bleeding vessels by injection with adrenaline, which serves as vasoconstrictive effect. How we will do the injection is we'll inject around the ulcer, four quadrants. However, there's a complications like operation, bleeding, and also necrosis. Then also we can do coagulation in the thermal or plasma, and also we can do hemostatic shifting. You know that the dual modality is better than single, so usually we will do injection with clip or either little probe, and there's no study proof superiority of either therapy. And this is the normal findings of the upper GI endoscopy showing gastroesophageal junction. Also, there's normal finding in for the gastric fundus, antrum, and also the central part of the duodenum. Next, we need to know the location of peptic ulcer. If it's gastric ulcer, usually the location is at the junction of the fundus and antrum along the lateral curvature. To be, how can we differentiate whether it's benign or malignant? If benign ulcer, will have smooth, regular, and rounded edge with a flat, smooth base, and surrounding mucosa that shows radiating folds. However, for malignant ulcer, usually they have irregular hip up or overhanging margins, and there's isolated mass protrudes into the lumen. Also, the folds surrounding the ulcer granted are nodular and also irregular. For the duodenal ulcer, as I said earlier, there's more than 95% found in the first part of the duodenum, and most are less than 1% at the This is example of endoscopic findings for the duodenal ulcer, gastric ulcer, and also gastric ulcer. So the first picture showing the duodenal ulcer is 65-year-old man with duodenitis presented with multiple disease and now the patient bacterial bismuth substrate, tetracycline, metronidazole, and also omeprazole for about 1 to 2 weeks. And then the second basic line of treatments are endoscopic therapy, plus minus follow up with endoscopic therapy. Endoscopic therapy depends on the porous classification. When this is up to 2 feet, we need to speak. And also there is a therapeutic endoscopy as I shared earlier, and also for the follow-up endoscopy. Usually we will repeat the scope in 6 weeks to document gastric ulcer healing. However, if ulcers still present, we will do another biopsy of the ulcer again, just to exclude malignancy for gastric ulcer. Then we will do extra biopsy for anti-urease test to confirm the elimination of the viral load. However, if there's non-gastric ulcer, we will do resection. Then there's transcatheter arterial embolization. This is the alternative to salvage surgery, where the celiac and superior mesenteric mesoderm is performed. In case of contrast extravasation, super selective elimination of the bleeding vessel followed by angiographic coiling from the distal to proximal vena will be done till extravasation is ceased. Patients with ulcer bleeding after failed endoscopy by doing transcatheter arterial embolization, it reduces the need for surgery without increasing the overall mortality and associated risk. However, it is associated with and then also we do surgical therapy in certain conditions. We will do surgical intervention when there's in duodenal ulcer there's failure of medical management or the patient non-compliance to the treatment. When there's perforation, also when there's persistent bleeding coming from the gastroduodenal, or when there's gastric obstruction. Whereas in the gastric ulcer, we will do surgical therapy when there's failure to heal after 3 months of the medical management, or when there's dysplasia or carcinoma, recurrence of the gastric ulcer, perforation, or also persistent bleeding. What are the surgical procedure that please mention? For the duodenal, we will do truncobactomy with scaloplasty or truncobactomy with ectomy, or can do highly selective bactomy. For the gastric surgery, we do wedge excision or enterectomy with incision of ulcer depending on ulcer location or even total gastric. Next, I will be sharing about the complications of the peptic ulcer disease, which the most common one is perforation. It occur commonly in the duodenal ulcer. The location usually at the anterior aspect of the duodenum. The perforation having risk factors like increasing age, female, use of vaccine, or history of cooking. So how did the perforation occur? The first one is the stages of peritonitis, where the stomach content is periodontal cavity. Then acid leads to severe pain in the gastric, vomiting, tenderness, and gulling. Then the second stage is the stage of reaction, where the bacterium secretes a lot of fluid to neutralize the content, and usually this stage lasts in about 6 hours. The third stage is the stage of bacterial peritonitis, where after 6 hours, bacteria from GIT escapes causing diffuse peritonitis. So we can find in those patients that have generalized gulling. And the terminal stage is when the patient develop into shock. That patient dia oleh dia shock. compression or insane. And duodenal ulcers are more common than gastric ulcers. However, the symptoms are different. And gastric ulcers, if we suspect gastric ulcers bleeding, this malignancy, I think otherwise, because ulcerated gastric cancer benign ulcer. Gastric anti-inflammatory agents and chemotherapy, including radiation therapy, are the mainstay of treatment, and elective surgery is very rarely performed. Long-term complications of peptic ulcer surgery may be difficult to treat, and the common complications of peptic ulcers are perforation, bleeding, or stenosis. And the treatment of the perforated peptic ulcer is difficult, although some patients may